my name is Brittany Roberts, and I'm a student at Maryville University. Today I will be performing a head-to-toe assessment on my patient, David Roberts. Prior to David entering the examination room, I had him empty his bladder and change into a gown. Following that, basic measurements were taken such as height and weight, his vital signs, and his distance vision was tested using the Snellen chart, and his near vision was tested using the Rosenbaum chart. So that partially tested cranial nerve 2. So moving on from here, I would start with David's head and his face. I'm going to start with inspection. David's head is nice and upright, it's rounded, and it's normocephalic and symmetrical. His facial features, such as his eyes and ears, are nice and symmetrically placed on his face. The skin is a nice tan color, it's clear and intact. Next I would kind of palpate his skull, make sure there's no hidden indentations or masses, which there are none. Also, when I was up here, I'd be looking at his scalp, making sure it's nice and mobile and non-tender, and it was free of any nicks or scaling. David's hair, when I looked around his head, he has no signs of alopecia. His hair follicles are nice and firm and smooth, and his hair is clean. Next, we would be moving on to palpating his facial bones. I'd be looking for any kind of tenderness or swelling. Next, I would be palpating his sinuses, his frontal, and maxillary. After that, I would be testing his temporomandibular joint. David, if you can open and close for me. Okay, and I'll be looking for any clicking, popping, or any discomfort. And then can you move it side to side? Okay, he has good tone. Next, David, I'm going to ask you to go through some, I'm going to be testing your facial nerve, so I'm going to ask you to make a couple of faces for me. Can you wrinkle your forehead? Okay, and then close your eyes tight shut. Okay, and then open. Smile real big for me. Perfect. You can relax. Puff out your cheeks. And then clench your teeth, and then purse your lips and blow out. Okay, and then stick your tongue out. Perfect. So the motor function for cranial nerve 7, the facial, was intact. Sensory would be tested with sweet and salty on the tongue. And usually when that is tested, the sensory portion of cranial nerve 9 is also tested, but using sour and bitter. So moving on, we're going to test cranial nerve 5. So David, if you'll close your eyes and then tell me whenever you feel you touch your face.
Yep. 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 Yep.
Okay. So the sensory portion of that is intact. Now I'm going to check motor function, if you can clench your teeth. Okay, and he has equal muscle tone on both sides, and then go side to side. Okay, perfect. So those functions are both intact. So next we will be moving on to looking at David's eyes. David has eyebrows above both of his eyes. His eyelids are nice and symmetrical. There's no signs of any ptosis. His eyelashes curve away from the globe. There's no crusting noted. If I look with my pen light, you can look up for me. His sclera is nice and white, and the conjunctiva is pink and moist. David, if you can close your eyes all the way, I'm going to palpate. Okay, and then you can open up. I'm going to palpate the lacrimal gland and down here. There's no expression of any exudate. So moving on from there, what I would be doing is doing some vision testing. So David, if you can, just tell me whenever you can see my fingers.
Yep. Yep. Yep.
Okay. And then next I will be looking at David's pupillary responses, so direct and consensual. So first I will start with your right eye, and you can just look straight ahead at me. Direct. Consensual. Direct. he had appropriate responses to that. Now, if you can look at the wall behind me, and then look at my finger. Okay, and he had appropriate constriction on that too. So next what I'm going to have you do is do what's called cover uncover test. If you can cover one of your eyes, look straight at me, and then uncover it. Perfect. Now do the other eye. Alright, get that done. Perfect. We'd be looking for any extra movement. So next what I will be doing is testing your cardinal or your extraocular muscles. So if you can look at the end of my pen and do not move your head, just only follow with your eyes. And be looking for any nystagmus. Okay, and then convergence, which he did perfect on that. So next what I would do is I would check for the red reflex. You will just look straight ahead. Okay, present in that eye. Okay, and then present in that one. So that is, after all those eye tests, cranial nerves 3, 4, and 6 are all intact. So next we would move on to David's ears. Again, we would look for alignment and placement. As I look around, so his ears are aligned with the outer canthus of the eye on both sides. And placement is symmetric on both sides of the head. Around his ears, there's no evidence of any nodules, deformities, or any ear drainage that I can see from here. So, next what I would be doing is palpating his auricle for any tenderness. Okay, so they're firm, immobile, and non-tender, which is good. So next what I'll be doing is taking a look inside of his ears at his tympanic membrane. He's pulling the ear up and back. Okay. Nice and pearly gray, light reflex, only minimal cerumen on that side. And up and back on this. And same on this side. So now what I'll do is I will test David's hearing, doing the whisper test. So if you can cover your left ear and tell me what you hear.
Cat.
Okay. And face the other side.
Orange.
So David's hearing is intact on that. And then next I'm going to do the Weber test to assess for any unilateral hearing loss. So just tell me if you hear it in one ear or the other or both. Okay. Next I'm going to do the ring test. I'm going to hold it back here. You let me know when you can't hear it any longer and I'll move it. You let me know when you can't hear it any longer.
Yeah. Yeah.
Okay. Then we'll do the other side.
Yeah. Yep.
So that was a normal finding because air conduction should be longer than bone conduction. So next so that means that cranial nerve 8 is intact for David. So next we'll be looking at David's nose. Again, it is nice and midline on his face. The same color of skin as the rest of his face. And his nares are nice and oval shaped. They're equal. There's no signs of any flaring. I'm going to test nasal patency. If you can include one nostril. Perfect. And then include the other one. Breathe in and out. Now I know David's sense of smell is intact, so I can tell you that cranial nerve 1 is functioning well. Otherwise, we would test it using liquid smell. So next, I will palpate his nose. Okay, it's nice and firm. And now I'm going to tip David's head back and look inside of his nose. And I'm looking at the nasal mucosa. It's nice and glistening pink. The turbinates, the middle and inferior, which you would be seeing, are not swollen. They're firm, same as the color around it. And the septum was nice and midline. There was no deformity to it, no perforations or bleeding. So next we will be moving on to assessing David's mouth. His lips are nice and intact. There's no signs of lesions or any cracking. David, if you would, open up your mouth some for me. I'm going to be looking in the buccal mucosa, nice and pink. The gums have tight margins with his teeth. He has 32 ivory-colored teeth with only minimal wear. So you'll lift your tongue up into the sides. That's where we'd be looking for any signs of any oral cancer. The tongue itself is nice and midline. I'll be opening your mouth a little bit more. Nice and midline, well papillated. If you'll put your tongue up towards the ceiling, the frenulum is present, and the ventral side is much smoother. I'll also have David tilt back. I'd be looking at the hard and soft palate. They're nice and intact. And the uvula is nice and midline. I'd take a little bit further back and to the oropharynx, the anterior and posterior pillars are intact. There aren't any signs of infection. My patient has tonsils removed, so those are not there. And the posterior pharynx is glistening and it's smooth, and there's no mouth odor. So what we would do next is we would test cranial nerve 9, the motor function of that, and cranial nerve 10. So David, if you can open up and say ah for me. Okay, the uvula was nice and midline. Next what I'm going to do is I am going to elicit the gag reflex. Okay, so that is nice and intact. And then I'll have David take a sip of some water. Okay, and he's able to swallow that without any issues. So next, cranial nerve 12 is what I would be assessing for his tongue. You can stick out your tongue. Okay, it's nice and midline, there's no tremors, it's symmetrical. You can put your tongue in your cheek and push it into my hand. Perfect. And tongue out, reach towards your nose and towards your chin. Alright, and that is all intact. So next, be assessing David's neck. So I'll actually have you remove your gown. Okay. So David's neck is nice and symmetrical with the musculature. As we look at it, it's nice and smooth. There's no evidence of any masses or swelling. There's no jugular venous distension or any carotid artery prominent. So next, what we would do is we put David through some range of motion. If you can tilt your head back, lean forward, but try to put your ear towards your shoulders. Okay, and then look to the right and look to the left. Perfect, and so those are all smooth and hopefully painless. So next I will do active range of motion, try to push against my hand. Okay, push against my hand. Try to lift up. Okay, and then lean forward. Okay, and then lean back. Perfect. So at that same time we were testing cervical range of motion also. So next we will go into assessing David's carotid arteries. We will palpate them one at a time. Those are nice, strong, and equal. Next I would be assessing that David's trachea is nice and midline. And it is, and there's no tugging, which is good. Next I will be assessing David's thyroid, so I'm going to have David take a sip whenever I'm ready. Okay, and if you can take a sip for me. Okay, and then another sip for me. Okay, so David's thyroid is nice and smooth. Next I will be palpating his lymph node, so if you can relax your head back, tilt it back a little bit. The occipital, and then the postauricular. the preauricular, tonsillar, submandibular, submental, the superficial cervical chain, posterior cervical chain. I'll have you turn your head a little bit. Deep cervical, deep cervical. Okay, and then supraclavicular, infraclavicular. Okay, and then I would look for the axillary. And those are all fine. So next I would listen for carotid bruits and any bruits in the thyroid. So David, the bell of my stethoscope. You can hold your breath. Thyroid. Perfect. No bruits present. So next I would go on to David's upper extremities. So you're making sure they're nice and equal. They're equal in size, length, and in muscle distribution. Also in hair distribution. They're warm, dry, and intact. There's no sign of any edema or any lesions anywhere. The nails are nice, hard, and firm. Capillary refill is less than 3 seconds. There's no signs of any clubbing. So next I would assess his brachial pulses and his radial pulses. And they're equal and strong. The next one I'm going to have you do is, if you can turn around, I'm going to assess your posterior back. Okay. So first inspection, the skin is nice and clear. There's no obvious skeletal deformities that we can see. The thoracic configuration, the AP diameter is less than the lateral, so there is no evidence of any barrel chest. I'm going to palpate his back. Palpate his costovertebral angle. Now I'm going to percuss for any pain, and there is none. So next I would continue to look with his respirations, regular chest rise and fall. No evidence of any issues with the breathing, regular rhythm and rate. So then I would palpate for thoracic expansion. At about T10, you can take a deep breath in and out. Okay, and that moves nice and symmetrically for me. So next I would do tactile primitive. And if you can say 99 for me.
99, 99, 99.
Okay, and that was nice and equal all the way down. Next I will percuss. Try to do it at an angle you can see me. Systematic fashion. You can lean forward for me and cross your arms. Okay, and lift your arms up for me. Okay, and that was nice and resonant. Next I'll be looking for a diaphragmatic excursion. So David, if you can, again, you'll kind of hug your chest. Take a deep breath in and hold. Okay, then you can breathe out a couple of times. Then you'll do a big exhale and hold. Okay, so about in this region. Okay. About 3 to 6 centimeters is to be expected, and his was at 5. Just for time limits on the video, we're only going to do one side on that. So last but not least, I would auscultate. Using the diaphragm and my stethoscope. Deep breath in and out. have David turn around. And looking at his anterior chest, first I'm going to still keep on the respiratory focus, and then we'll go to cardiac, but inspection is the same. He has regular chest rise and fall. The respirations are completely unlabored. There's no signs of any retractions to indicate any distress, regular rate and rhythm. I do not see any pulsations or heaves when I look at him. So next I would go on to palpating. So again, put my fingers about here. Take a deep breath in. Okay, and that was nice and equal. And now just say 99.
99, 99, 99, 99.
Okay, and the tactile primitus was all equal. So then we would go into percussion, just in the anterior. Okay, and that was resonant sound, so that was all normal. So next I would listen to his lung sound. Just take a deep breath in and out, and I'll be listening with my diaphragm. Okay, those are nice and clear. So next, what I would do is move on to the cardiac part of it. So again, the inspection was the same. There's no heaves or pulsations from what I could see. So I'll have David I'll have him lay back. The anterior thorax, there was no skeletal deformity. I'm just going to be palpating first across his chest to make sure there's no tenderness. Then I would palpate his precordium. I would start at the right sternal base. Go to the base. Left sternal border. And then apex. And then I would also palpate for the apical impulse. Nice and steady. But no evidence of any heaves, lifts, or thrills whenever I did that. So next what I would have David do is I would auscultate, because we don't percuss for cardiac silhouettes anymore. So you would have a thorough one would be listening with the bell and the diaphragm, 3 different positions, but just to save time, we will do one. So I'm going to have David actually sit up, so you can see a little bit better, and kind of lean forward a little bit, not too much about there. First, I'm going to listen with my diaphragm, the aortic, pulmonic, herbs, tricuspid, and mitral. And then, since it's one-sided, listen with the bell a little bit lighter, to the same point. Herbs, tricuspid, mitral. Okay? So everything was fine, normal S1, S2, no evidence of any murmurs. So next, I'll have David lay down for me, and I'm going to be assessing his abdomen. So for this, I'm going to look across, make sure there's no evidence of any bulges or masses. His abdomen contour is flat, it's symmetrical. Characteristic-wise, the umbilicus is nice and midline, and it's inverted, which is normal. There's no evidence of any distension or bulges. I can't see any movement that would indicate peristalsis, but I do see a little bit of a pulsation, probably the aorta, which is normal in our thin patients. So next I would auscultate all 4 of his quadrants, the diaphragm, listening for clicks and gurgles, okay, and those are all fine. And then I'll be using the bell of my stethoscope to listen to the arteries to assess for any bruits. So the aorta, renal, the iliac, and then the femoral. Okay, and there was no evidence of any bruits there. So next I would go into percussion, and I would percuss all the quadrants, use all signs of timpani. So from there I would percuss up to assess David's liver span. So, use some little pieces of tape to kind of mark it. Okay, start in area timpani. Okay, and then I come down. Alright. The normal is about 6 to 12 centimeters. And David's is right at about 8. So we are within normal limits on there. And then I'll have you kind of turn to your side a little bit. And the spleen is kind of difficult to get to, but we would be assessing for splenic dullness on the left side. So that is normal. Just to go back to normal. So after that, we would go to palpation. I'm going to start with light. This is just getting the patient used to a feeling and any muscle rigidity. And then I would go with deep. So all the quadrants. Okay. So then I would look at the right costal margin. I'm going to kind of do a hook. David, if you can breathe in and out. Okay, and I could feel the edge of David's liver because when he breathes in and out, it displaces it downward. And then I'm going to assess for David's spleen over here at the left costal margin. Okay, and you can't assess that, or I couldn't palpate it on him. So next I will palpate the kidney. You take a deep breath in. Okay, and deep breath out. Okay, now I was able to capture the kidney on the right side. And we'll go to the left. Deep breath in. Deep breath out. There we go. Unable to capture the left one, but that's normal. And then I'll palpate his aortic pulsation. A little bit left in midline. And then I'll have David sit up very slowly. I'm going to be looking as he sits up. He has muscle prominence, which is normal in our thin individuals. And there's no evidence of any extra bulges or masses, which is good. So from there, I would look at David's lower extremities. They're equal in length, size, mass, muscle mass, and hair distribution. So I would assess the temperature, equal all the way down, and there's no evidence of any edema. Skin is warm, dry, and intact, no lesions, and would also be looking at his nails. Again, they're nice, firm, and hard. Capillary refill is fine, and there's no evidence of any clubbing. So now I'll kind of have him turn the pulses I'm going to do popliteal, which will be a little bit weaker and more difficult to find, but they are present. And then I would do his dorsalis pedis, which is right on top of his feet. And then the dorsalis pedis, or posterior tibial, I'm sorry, right behind the ankle. And so we are all intact on those. So next we would go to doing a little bit of the reflexes and the testing the spinal range of motion. So I'm going to try to move this back a little bit so you can actually see what I'm doing. Okay, so first I'll start with the brachioradial. Okay. Alright, those are normal. And then for the knee. Okay. And then the Achilles tendon, you just kind of relax your foot in my hand. Okay. And you relax your foot. Okay, those are all equal and normal responses. So now I would test David's cervical spine. First you'd be inspecting. He has the concave on the cervical area, convex on the thoracic, and concave again on the lumbar. So I would walk my fingers down. Sorry, turning around facing feet. I would walk my fingers down his spine. Make sure it's nice and straight. Then also down his muscles to make sure there's no tenderness. Okay, so that is all fine. With the cervical range of motion, like I said, we did that earlier with the spinal accessory nerve, cranial nerve 11. That was all intact. So to assess down here, what I'm going to have you do, David, is to stand up from the table. And move the table out of the way. Over here. Okay, and I will have David, if you can turn sideways, lean back a little bit for me. This is extension, that was normal. Okay, and then turn again. And then just kind of angle to the side. Okay, and then keep your hips like this, and then just turn to the sides for me. And those are all smooth. And then I'm going to have David lean forward for me to touch his toes. I'd be assessing to see if there's any unequalness, but he's all symmetric down here. His hips sit at the appropriate place. So, therefore, the spine range of motion was assessed. There's many other joints that can do it, but again, for the sake of trying to save time and requirements, we will be cutting it off here. So thank you very much for watching.